Welcome to part 2 of this series, and we're going to cover the changes made to the federal government's regulation of prescription opioids. But before we get into that, let's talk more about the reality of the situation. The fact is, there never was any good data linking opioid prescriptions to deaths from unintentional injury. A newer peer-reviewed study published in the journal Injury looks at the period we're going to be talking about from 2006 to 2017. That study concluded, data were available for all states and the District of Columbia. Opioid deliveries increased through 2012 and then declined. Total injury-related mortalities have been increasing steadily since 2012. Opioid MEDs did not show a consistent or statistically significant relationship with injury-related mortality, including with any subgroups of unintentional deaths, suicides, and homicides. In every state examined, there was no consistent relationship between the amount of prescription opioids delivered and total injury-related mortality or any subgroups, suggesting that there is not a direct association between prescription opioids and injury-related mortality. But it's not a surprise to anyone who's been looking at the data. Even CDC data shows that states with high prescribing rates don't have higher rates of opioid overdoses, even when limiting the analysis to deaths involving pain pills. All this began in 2006, and we'll talk more about that year in future parts, but that was when the government engaged in a very ham-fisted approach to trying to stop opioid deaths by reducing prescriptions. Well, they reduced prescriptions all right, but the opioid-related deaths increased and even accelerated. Why? For a couple of reasons. The first being that people who overdose aren't pain patients. You're talking about two entirely different demographics with very little overlap between them. Going after pain patients is going after the wrong group. The second is, when it is pain patients, this arbitrary limiting of their medicine drives them to the black market. Pain is a great motivator, and those in severe pain will go to great lengths to try and abate it. But, of course, on the black market, as we covered in part 1, there's no dosage control or safety protocols. A 2017 study published in the journal Addictive Behaviors found that the people entering addiction treatment said that heroin, not prescription opioids, were the first opioid they tried, and that share rose fourfold between 2005 and 2015. They found, our data document that, as the most commonly prescribed opioids, hydrocodone and oxycodone, became less accessible due to supply-side interventions, the use of heroin as an initiating opioid has grown at an alarming rate. Given that opioid novices have limited tolerance to opioids, a slight imprecision in dosing inherent in heroin use is likely to be an important factor contributing to the growth in heroin-related overdose fatalities in recent years. And that only got worse as fentanyl entered the black market, which is far more potent than heroin, but easier to make because you don't need a grow operation. You make it in a lab, not from opium poppies. 73% of opioid-related deaths in 2019 were from black market fentanyl, up from 14% in 2010. The problem was made worse in 2014 when the Obama administration moved prescription opioids from Schedule III to Schedule II, making them among the most heavily regulated prescription drugs. That severely limited the ability of pain patients to get medication, but it did nothing for opioid addiction and overdoses. In fact, as usual, the addiction rate stayed constant, but overdose rates rose dramatically. And something else rose that we'll cover more thoroughly in Part 5, but it deserves mention here. Deaths of despair. In other words, people purposefully ending their own lives because they just can't deal with the pain that is no longer being adequately treated. The war on pain patients was a colossal failure, and yet government doubled down on it, restricting access to pain medication even further, citing flawed statistics and even misrepresenting or even lying directly about the data. Take a look at this graph. So at the start, you do have a rise in deaths from commonly prescribed opioids. But the stats don't break it down as to how many of them were prescribed opioids and how many of them bought them on the black market. The graph also doesn't tell you that, overall, drug overdose deaths have been increasing since 1979, with no changes associated with the rise and fall of opioid prescriptions. But look at what happened after the move to Schedule II. The big rise isn't coming from prescription opioids. It isn't even coming from black market heroin. Despite a rise since 2010, the big rise is from other synthetic opioids, which pretty much means IMF, illicitly manufactured fentanyl. If you're going to restrict opioids for pain patients, you need good, solid evidence that people who are prescribed these opioids are the ones getting addicted and dying of overdoses. And overwhelmingly so, the data show the exact opposite. In 2016, the CDC published warnings about the grave dangers of patients exceeding 90 MMEs per day. MME is morphine milligram equivalent, which is how doctors measure equivalent doses of different opioids. Hydrocodone has an MME of 1, meaning 1 milligram of hydrocodone is the same as 1 milligram of morphine, whereas with oxycodone it's 1.5, where 1 milligram of oxycodone is the same as 1.5 milligrams of morphine. They also claimed that acute pain patients, such as patients following surgery, generally need no more than 3 days of treatment with opioids and should have no more than 7. The result of this is that doctors, pharmacists, insurers, regulators, and legislators limited patients and doctors to prescribing no more than this, and chronic pain patients who were already above 90 MMEs, even if they had stable pain results and no signs of addiction, were forced to cut back. Fortunately, there were some in the medical community who started pushing back. In 2018, Senator Rob Portman sponsored a bill that would have imposed a nationwide limit of 3 days on opioid prescriptions based on the CDC's publication. The AMA pushed back because that was not sound medicine and wasn't based on any actual CDC data. I discussed this in 2018 with Esoteric Entity. And we've criticized the AMA before, but they've actually done a good thing recently in opposing a national 3-day limit on opioid prescriptions, which is done, of course, out of concern for an epidemic that, as we've covered repeatedly, just isn't happening. Republican Senator Rob Portman of Ohio introduced the bill with his spokesman saying, quote, "People are dying around the country every single day because patients are being prescribed too many opioid pills at one time." That has nothing to do with it, Portman. In fact, as we covered, overdoses are going up as prescriptions are going down. It's happening because pain patients can't get the prescriptions, and in desperation, they turn to the black market where they have no idea what they're getting, how potent it is, or what it's cut with.
Yeah, well, I mean, that's pretty obvious. I mean, you get a completely regulated market with a relatively high demand, well, you get bootlegs.
And insert Archer meme here. Do you want more overdoses? Because that's how you get more overdoses.
I mean, just every time that they've ever tried prohibition, why are they still trying prohibition? Doesn't work.
Quote, "A 3-day limit is common sense based on CDC guidelines, and Senator Portman is going to stand up and fight for what is right." The problem is, it isn't the CDC guidelines, and also appeal to common sense is a fallacy, but the CDC guidelines actually say, quote, "When opioids are used for acute pain, clinicians should prescribe the lowest effective dose of immediate release opioids and should prescribe no greater quantity than needed for the expected duration of pain severe enough to require opioids. 3 days or less will often be sufficient. More than 7 days will rarely be needed." And CDC guidelines also say, quote, "Clinical decision-making should be based on a relationship between the clinician and patient and an understanding of the patient's clinical situation, functioning, and life context. The recommendations in the guideline are voluntary rather than prescriptive standards. clinicians should consider the circumstances and unique needs of each patient when providing care. In other words, not by a politician who has no medical training and hasn't examined any of these patients.
Right, exactly. And that's just a good way to tell when you should avoid something, whether it's a political position or just an argument, is if it's commonly used on that side of the argument of appealing to common sense. You see that all over the place with climate change regulation or raising the minimum wage or gun control. You hear that all the time. It's common sense. Well, if it's common sense, you should be able to explain it in a way that most people would understand.
Yeah, if it were common sense, you shouldn't have to say that it's common sense. You could just explain why it makes sense.
Right. It's pretty self-evident what you're doing. All you're doing is skipping explaining your position and just telling people what they should think about it.
And also, Republicans want to get the government out of healthcare unless doctors are prescribing medicine they don't like, in which case, get the government into healthcare.
Yeah, no, they don't. They just want to cut spending on it slightly. They don't want to get rid of public health care. You could see that with what Trump's doing. Republicans love universal health care, and it's pretty obvious as to why they love it. It's because it gives them something to run against, and by cutting spending to it, they can pretend that they're doing something about it.
Yeah, they can be the loyal opposition.
Yeah. It's pretty obvious. I don't know why there aren't more people who see that.
And unfortunately, politicians and even healthcare providers have been misinterpreting these CDC guidelines as a call for strict limits and also applying it to chronic pain as well as acute. Such a limitation would leave many chronic pain sufferers bedridden and even suicidal, as we've covered before. In fact, 2 states, Florida and Kentucky, have already imposed 3-day limits. Florida will allow 7-day prescriptions, quote, if medically necessary, based on provider professional judgment. Now, think about what that means. That means that in Florida, if you're a doctor, you cannot write prescriptions for more than 7 days, even if it is medically necessary based on provider professional judgment.
Yeah, aren't there plenty of people who go under surgeries who ask for medication after 7 days?
Oh, yeah. I mean, some surgeries, you can be in pain for months afterward. It just depends on how bad it is, whether or not there are any complications or whatever.
Yay, so you're putting people in agonizing pain for weeks on end. No wonder so many people turn to the black market.
Yeah, I mean, pain's a great motivator, And besides, what does a prescription mean other than an expression of medical necessity based on provider professional judgment? I mean, isn't that the whole point of prescriptions to begin with? That's why government passed all these laws about them.
Yeah, I suppose so. I mean, it's more so the government can control what people get what and the manufacturers of the medication.
So thankfully, the AMA came out against this, saying, quote, a strict 3-day limit ignores the admonition from the CDC guideline that clinical decision-making should be based on a relationship between clinician and patient, an understanding of the patient's clinical situation, functioning, and life context, misstates the actual recommendation of the CDC and applies limits to clinical situations to which they were not intended to be applied. Most patients with opioid use disorder have trouble accessing care as payers and others put up obstacles.
I think that's the most awful part about regulation just of any kind. That's creating the problem. And all the government's doing is just pointing at the market and saying, look, it's because of this unregulated aspect of society. We need more regulation.
And that brings us to this week's moron, Jackie Kucinich of the Daily Beast. She says that the reason this limit hasn't been made mandatory is that Congress is too scared of the AMA.
What? Oh, man.
Yeah, I guess to her, the AMA is like the NRA is to gun control people. The only reason we have guns in this country is because the NRA has spent zillions of dollars to buy off politicians. Sounds like the same thing to me.
Yeah, I mean, forget the long history of political funding against drug use and against the freedom of trading.
Her article begins, as the opioid epidemic ravages the country. No, it doesn't. We've debunked this so many times, it's embarrassing. And I mean, not only does she blindly and uncritically accept the insane claims of these politicians, she acts like anyone not calling for more regulation of healthcare is just in the pocket of the AMA and is calling for nothing less than the destruction of all society. But no, it's this insane war on drugs that's causing all the destruction, because politicians get their little panties in a wad over the thought of a few people getting high. We have barriers in the way of legal means of using drugs, not only to get high, but for other reasons as well, such as pain relief. Hospitals make patients suffer because they limit their morphine way below what's necessary to avoid health risks. Doctors refuse to help patients manage their pain for fear of having their license pulled. People who have no criminal background whatsoever are subjected to regular drug testing. If anything, pain sufferers are way under-medicated, and politicians are trying to make it worse.
Yeah, that's just cruel.
And it even resulted in the CDC having to engage in backpedaling, claiming that the 2016 publication was just loose guidelines and it wasn't ever supposed to be a hard limit. But as covered in 2022, it's ridiculous for them to claim that they were merely misunderstood when doctors, insurers, and politicians across the board took it the same way. Well, it looks like we're finally getting some good news on the pain management front. I've said it before, I'll keep saying it. The CDC is an organization of politics, not science, and pain management is actually one of the worst things they've been involved in, creating the most damage for people. But we have a little bit of good news, as elucidated in this Reason article by Jacob Sullum. So they have revised and expanded pain treatment guidelines that are at least a marginal improvement over their god-awful 2016 guidelines. They actually mention patient abandonment 8 times and include 2 occurrences and say in bold and italics, clinicians should not abandon patients. And as we'll see here is kind of a recurring theme, why would they have to say that? You would think that, clinicians, doctors with their patients, that would be kind of the default. Oh, I'm not going to abandon my patient. But that's what these guidelines do. As Sullum says, something has clearly gone terribly wrong when clinicians have to be reminded that they are not supposed to abandon patients. At the same time, the CDC's acknowledgement of the problem signals its willingness to address the needless suffering caused by the 2016 guidelines, which resulted in undertreatment, reckless tapering of pain medication, denial of care, and pro-Crustian policies that prioritize reductions in opioid prescribing over the interests of patients. So, we're talking about opioids being prescribed for chronic pain. We're not talking about, like, black market fentanyl and things like that. And so they were setting these arbitrary limits and saying chronic pain patients who are already above those limits should be forced to comply with an arbitrary limit that was not based on anything scientific or medical or research-based or anything. And they said they also touched on acute pain because long-term opioid use often begins with treatment of acute pain. Lie. Yeah, we've covered why that's a lie. Ostensibly, the guidelines were purely advisory, but in practice, many patients found, to their dismay, they were mandatory. And this is something that it's pretty much a recurring theme. There basically is no such thing as a request or guidelines from government. They have people with guns. Law enforcement says, can we search your car? Well, how do you interpret that? They might be able to get away with it. Well, no, we just asked. It wasn't a warrantless search. We just asked to search their car. Well, yeah, but you don't really feel that, you can say no, can you? So that's what they rely on. So in the new guidelines, the CDC says, Some policies that were purportedly drawn from the 2016 CDC guideline have, in fact, been notably inconsistent with the 2016 guideline and have gone well beyond its clinical recommendations. They just didn't understand it. They didn't understand what they were saying because I guess they're dumb. I guess doctors are dumb and they don't understand that when the CDC makes guidelines that they mean something completely different from what they actually say. So all this misapplication, the CDC notes that the FDA has advised that the risks of rapid tapering or sudden discontinuation of opioids in physically dependent patients include acute withdrawal symptoms, exacerbation of pain, serious psychological distress, and thoughts of suicide. Well, at least suicide's getting a mention in. And the CDC is referring to the safety announcement that the FDA issued 3 years ago in response to complaints from patients and pain specialists. Notably, the FDA warning mentioned not just thoughts of suicide, but completion of the act, as we've covered. When patients respond to CDC-inspired medical practices by killing themselves, it might be time to admit that the agency issued its advice without sufficiently considering the potential for unintended but foreseeable consequences. Yes, as we covered, these were very foreseeable. Lots of people were saying that this was going to happen. But the CDC never quite admits that in the new guidelines. They're just saying it's misapplication. They say, this voluntary clinical practice guideline provides recommendations and does not require mandatory compliance. The clinical practice guideline is intended to be flexible so as to support, not supplant, clinical judgment and individualized, patient-centered decision-making. But the new advice does retain a bias against opioid treatment, but, unlike the 2016 version, does not imply that daily doses of more than 90 mme for chronic pain are inherently sus. Yeah. You ask me, the CDC is kind of sus. Maybe we got an imposter among us here. Alright, so this is the CDC. Payers and health systems should not use this clinical practice guideline to set rigid standards related to dose or duration of opioid therapy. And they should ensure that policies based on cautionary dosage thresholds do not result in rapid tapers or abrupt discontinuation of opioids. For patients already receiving higher opioid dosages, clinicians should carefully weigh benefits and risks and exercise care when reducing or continuing opioid dosage. Again, kind of weird that they have to say that, don't they? Yeah, weigh the benefits and risk and exercise care. Isn't that what they should be doing anyway? Is it really their fault, the CDC? Huh? Or is it yours? Is it yours? Because I think it's yours. If risks outweigh benefits of continued opioid therapy, clinicians should optimize other therapies and work closely with patients to gradually taper to lower dosages, or, if warranted based on the individual clinical circumstances of the patient, to appropriately taper and discontinue opioids. Unless there are indications of a life-threatening issue, such as warning signs of impending overdose, confusion, sedation, slurred speech, opioid therapy should not be discontinued abruptly, and clinicians should not abruptly or rapidly reduce opioid dosages. That part's good, at least. So Solom says, these warnings are welcome if overdue, but it's not really clear what working with patients means. That's just the kind of, politispeak that they always seem to engage in. Right. And then they have a caveat that they've underlined, the CDC underlined this, not reason. They're just passing along the underlining. The recommendations related to opioid dosages are not intended to be used as an inflexible, rigid standard of care. Rather, they are intended to be guideposts to help inform clinician-patient decision-making. The problem is they're bad guideposts, but whatever. Further, these recommendations apply specifically to starting opioids or to increasing opioid dosages, and a different set of benefits and risks applies to reducing opioid dosages. And the CDC acknowledges the concern that advice tied to specific dosages might lead to suboptimal care and misguided policies. Gotta love that word, suboptimal. As opposed to disastrous, as it is for so many pain patients. All right, we got Lynn Webster, former president of the American Academy of Pain Medicine. The CDC does not acknowledge the weak scientific basis for MME thresholds, which do not take into account wide variation in how patients metabolize and respond to pain medication. The CDC clearly prefers that doctors treat pain with something other than opioids whenever that is feasible, but it acknowledges that NSAIDs such as ibuprofen also carry risks and may not provide adequate relief. And while its discussion of non-pharmaceutical treatments may strike pain specialists as excessively optimistic, it does not insist that patients try every other conceivable option before opioids. You do want the non-pharmaceutical stuff. You want to attack this from multiple directions. So, if the heating pad will help. It helps me sometimes to put a heating pad on. You do that. You try this from every possible action. But, I don't see how you can do it without opioids. I take NSAIDs too. I take naproxen, and I just take the over-the-counter amount. And I take that twice a day, and it helps. And I found out how much it helped when I got my colonoscopy, and I couldn't take them for 24 hours beforehand. Yeah, if you remove any one part of your pain management regimen, yeah, it can be disastrous. But opioids are so crucial to this. It's just really, really terrible that they're still continuing to say things like this next part. Opioids should not be considered first-line or routine therapy for subacute or chronic pain. I'm going to disagree with that. They're the only real painkillers we have. NSAIDs work, by reducing inflammation. Gabapentin works, by reducing neural activity, and that can, reduce neuropathic pain. It's actually epilepsy medicine. But that's all indirect. Opioids are the only ones we have that work directly on our pain. But at least they say, this does not mean that patients should be required to sequentially fail non-pharmacologic and non-opioid pharmacologic therapy or be required to use any specific therapy before proceeding to opioid therapy. The problem never was, oh, you had surgery, oh, you had an accident, here, have some opioids. That was never the problem. That was never, ever, ever, ever the problem. And the data sings that. The data sings the truth of that statement. And so then you've got all these time limits, the expected duration. No, they're not limits, it's just an expected duration. A patient taking hydrocodone after an injury or surgery, for example, may find that he is still in pain after his pills run out. The CDC is so keen to avoid the risk that unused pills will be diverted to non-medical use that it is willing to let such patients suffer until they manage to get another prescription. And the CDC says, clinicians, practices, and health systems should have mechanisms in place to provide timely reevaluation for the subset of patients who experience severe acute pain that continues longer than the expected duration. But as Solom says, this seems an awful lot like wishful thinking. Even with mechanisms in place, patients will suffer from unrelieved pain while they're jumping through these hoops. There is an unacknowledged value judgment here that says the war on drugs takes precedence over patient welfare. Likewise, with the CDC's position that opioids are not first-line therapy for patients recovering from dental surgery, the aim here is to prevent unnecessary prescriptions that might contribute to opioid misuse. But pursuing that goal means that many dental patients who find that Tylenol and Advil are inadequate will just have to suck it up. The CDC's bias against opioids does not seem to be justified by the addiction risk it emphasizes. I think this is similar to the studies we've covered before. 2015, 100 million Americans use prescription opioids, including non-medical users as well as bona fide patients. About 2 million of them, slightly more than 2%, qualified for a diagnosis of substance use disorder, which subsumes both what used to be known as substance abuse and the more severe substance dependence. By comparison, data from the same survey indicate that 9% of past-year drinkers had an alcohol use disorder in 2015. As for fatal overdoses, 2015 study of opioid-related deaths in North Carolina reported in Pain Medicine found 478 fatalities among 2.2 million residents who were prescribed opioids in 2010. I'm one of those. And in case you haven't noticed, I did not die from an overdose. I think I would have noticed that. An annual rate of 0.022%. Prescription opioids are not the problem. But Webster notes that the CDC dubiously blames opioid prescribing for increases in drug-related deaths between 1999 and 2010, without acknowledging that the upward trend in fatalities accelerated after the government succeeded in reducing the use of opioid pain medication. I've shown the data on this. As opioid prescriptions fell, opioid-related deaths, primarily involving heroin and illicit fentanyl, rose to record levels. It's really the fentanyl. The heroin, if I remember the data properly, actually went down. And that was after Obama moved opioids over to Schedule II. Drug warrior Obama. Even when the CDC concedes that opioids are necessary, that message may be lost amid all its warnings about the dangers of these drugs. And the New York Times reports that the guidelines advise against prescribing opioids except for traumatic injuries such as burns and auto accidents. If Times Health Law reporter Jan Hoffman got that impression, clinicians might as well, leading to further misapplication of the CDC's advice. So we also have Kate Nicholson, president of the National Pain Advocacy Center, who says that the remaining references to MME thresholds are not adequately justified and could still be lifted by policymakers. She also suggests that expanding the guidelines to cover shorter-term pain opens a can of worms and may confuse more than clarify. While a lot has improved, a lot still needs to be addressed. Then there's Bob Twillman, former executive director of the Academy of Integrative Pain Management. He says, in particular, the elimination of specific dosage numbers is welcomed because those were very easy for policymakers and payers to latch onto in setting policies. While it's good that they're removing those, I fear that it's a bit like closing the barn door after the horse has escaped. There's a lot of work that needs to be done to modify or eliminate policies that were tied to the specific numbers in the 2016 guideline, and I'd like to see CDC play a role in that work. And this last part here is going back to Webster. The good thing is that the explicit dose limits were removed and the days of opioid supply for acute pain are not specific. But although they say that the guidelines should not be an inflexible standard of care imposed on specific populations, they do not expressly state that law enforcement and policymakers should not use them to set a standard of care or to prosecute providers, because that's what they've been doing. And we've seen that. Oh, you've been prescribing this person more than this completely arbitrary amount that isn't backed up by any science or research. Well, we're arresting you. We're taking your medical license away. Yeah, that's a huge problem. And it stems from the CDC, from the fact that the CDC does not follow the science. And so Webster questions why the CDC felt a need to advise doctors about pain treatment in the first place. That function should be left to professional organizations. Several experts in the field predicted the outcome of the 2016 CDC guidelines before they were issued. The debacle with the 2016 CDC guidelines illustrates the reason the CDC should not be imposing their views on how pain medicine should be practiced. Yet they're still going to do it. They are. As long as they've got their wonderful war on drugs, and as long as they have scapegoats that they can point to, and us pain patients are great for that, then they're going to continue to do it. And it's like I pointed out in a fairly recent episode of the podcast, it's like on the one hand, they want to blame pain patients for everything. On the other hand, they're acting like illicitly manufactured fentanyl is just the worst thing ever. You have all of these really dramatic Policemen going, "Oh no, I touched fentanyl powder. I'm having an overdose. Oh no, I breathed in some fentanyl odors. I'm having an overdose," when it doesn't work that way at all. And yet they don't see the incongruity there. They don't seem to see the contradiction in saying that the illicitly manufactured fentanyl is like the most dangerous substance on the planet, which, I mean, if you can get an overdose just through contact with the skin, then why do they bother injecting it, you know? Am I right? Between that and pain patients, prescription opioids, doctors and pain patients are responsible for all of this. Well, it can't be both. Can't be both. But they'll make it out to be. That's what they do. Because actually trying to solve the problem just might admit that their authoritarian tactics don't do any good, and they'll have to give up their power to actual people, actual patients, actual doctors, people who are actually in a position to solve the problem. And as long as that's not them, then they're not going to have anything to do with it. I want to show you one of the things that we as pain patients have to go through. I got this letter recently from my insurance company. I get letters like this every so often. Just listen to some of the things they try to tell us. You have options to treat pain without opioids. Yeah, do you think we're not already doing that? People say, well, why don't you just take, naproxen or an NSAID like that? Well, we are. Hey, why don't you try heating pads? Well, we are. Pain management is something you attack from multiple different directions, but people just pretend like it isn't. Opioids can put you at risk for substance abuse disorder, accidental overdose, or even death. I've been taking them for almost 18 years with no sign of addictive behavior and no chance of overdosing. Because the prescription medicines are incredibly safe. They just don't do that. And they talk about all sorts of side effects, tolerance, physical dependence, constipation, nausea, vomiting, dry mouth, drowsiness, etc. I don't experience any of these. Maybe some people do. But that's going to be important later on in the letter, so keep that in mind. Given these risks and side effects, it's important to work with your doctor to make sure you're managing your pain the right way. Talk to your doctor about ways of managing your pain without using prescription opioids. Yes, we do that too. Some of the options below may have fewer risks and side effects. So what are they? Well, I mentioned NSAIDs like naproxen. Some medicines used for seizures, which can also help with certain types of nerve pain, like gabapentin, which I'm already taking as well. And muscle relaxants, and they mentioned tizanidine, which I'm taking, but I can't take it during the day because I have pretty massive side effects. For me, tizanidine is like a big slap in the face. I wouldn't be able to drive with it or anything. It's fine at night because I'm going to sleep, and it really does help me sleep, so I do that as well. But some of these just have so much worse side effects than the hydrocodone I take. Oh, but it gets worse. They also recommend acupuncture for low back pain, chiropractic services, mental and behavioral health services. Pain is all in your head, don't you know? And we'll tell you about these. Protect yourselves from an overdose, blah, 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 blah. Yeah, talk to your doctor about naloxone, that sort of thing. I just want to make sure everyone understands what just happened, what the insurance company actually sent to me. This may be a bit of a digression, but we need to talk about acupuncture since, as you just saw, it's actually being recommended for pain patients. Acupuncture does not work. It is complete 100% fake medicine. Total and complete quackery. It's not some ancient wisdom like people are making it out to be. Medical documents found from 2nd century China make no mention of acupuncture. It wasn't until the Ming Dynasty around the 14th century that anything resembling modern acupuncture was published. But over the next 300 years, its use declined. The Chinese people saw it as something that didn't work, something that was superstitious and irrational. In 1822, recognizing that it was a fraud and a scam, the practice was outlawed throughout China and excised from the Imperial Medical Institution. It was also outlawed in Japan. Chinese medicine at the time was very modern, and they began adopting westernized medicine. And then came Mao Zedong and his great leap forward. He had promised his people universal health care, and he couldn't deliver. So, pretty much out of whole cloth, he made up traditional Chinese medicine, or TCM, which included a lot of abandoned practices, including acupuncture. Mind you, Mao himself never used it, and his physician used modern medicine instead of TCM. So acupuncture is nothing but an ancient superstition that was revived as a fraud when a political leader wanted to convince his people he was giving them real medicine when he wasn't. And now, a major American insurance company is recommending it over prescription opioids, which are completely safe and proven to work. How unconscionable is that? This is just a tiny indication of what pain patients have had to deal with as a result of all of this, with the policies having no effect on addiction and overdose, and even making the problem worse. In part 3, we'll talk more about overdoses, who's overdosing on what, and what the cause is. Stay tuned.